Right. Give me a few seconds. People are coming. Right. The first thing is about, I think there is some issue with the pin. I'll just come back in a minute. Okay, right. Station 5, time management. I put the first, the time management. That's the biggest, I would say, in terms of challenge, in terms of BCC 1 as well as 2. Before going to the time management proper, people need to know what this exam is expecting from us, and then what is the structure for, and who is this for. I will also record this. So first of all, in terms of time pressure, why that time pressure comes in? Where do they get that like 10 minutes or the 8 minutes without the examiner comes on? This exam is for registrars or the medical registrars. So people who had done the training, what we call like a first year and second year training, and then they move on to third year training, which is like a consultant to become a consultant, any specialty. Let's say want to become a nephrologist, want to become a neurologist, and anything like a specialist training. When they move on to specialist training, they have to clear this exam. That is what MRCP PACES is. And we have already done 2 parts, just the PACES is remaining. So this is where the route is. So specialist training 1, first year, specialist training 2, second year, and then specialist training 3 is the which one before that. So 1 and 2, 2 years of training, and then you clear this exam, then get into the specialist training. When you talk about specialist training, that's where it comes in terms of, yes, the registrar, the medical registrar role, and we need to clear the exam. And when you talk about medical registrar, who is a medical registrar? What is his responsibilities? So he is the, let's say, the medicine man, what we call. Say all these I'm telling for the people who are not working in UK to understand the system first, then only you can clearly put practice and then get ready for the exam. The first thing is medical admission. So he or she, the medical registrar, is the person who will get all the referrals from the entire hospital regarding the medicine, any medicine, any acute medicine or any problem anywhere, entire hospital, they'll get the referrals. The second thing is about the GPs will get the helpline for GPs, either through the phone call or the referral, so anywhere else is helpline. And third one is for the distressed relatives or the distressed the patients as well. So if there is any problem, there's a, in fact, to easily say, see, apart from the consultant, if you remove the consultant out of the equation, medical registrar is the senior most role in the entire hospital. So that is where the responsibility comes into play in terms of clear assessment and get a plan. And the consultants are looking in terms of a medical registrar who can take a clear history and who can take a clear examination, do the clear examination, and then get a plan so that there won't be anything disturbed or in terms of, when I say disturbed, it's not the patient health needs won't be disturbed. So that's the main thing. Assessment. When we do that assessment, so the situations where, or let's say, for example, the ward rounds. See, when we say ward round, it's what we say in terms of like a usual acute medical intake. And again, I'm saying this for people who are not in UK, what we call acute medical intake. So people get admitted to emergency assessment unit or medical assessment unit or even in A&E, and then from there they go into the wards when or the specialty wards. So this is the normal route, and when going that, the assessment place is the where the medical registrar will do the assessment. So that's the first place, port of call, in terms of where people need to go. The second thing is about the ward round. Let's say the medical registrar is doing a cardiology, and then you will be in a cardiology ward. So you will see cardiology patients like a part of the ward round. And the third scenario is the clinic. Clinic is where, like an outpatient clinic, we have like a set up date and time, and we'll invite people, and people will come in there. So need to decide about the problems and then take it from there. So this is the setup. When we are looking at this setup, when we are expecting to be the most responsible person other than the consultant, senior most person other than the consultant in the whole hospital, and helpline for the GP, and then like a powerful communicator for distressed patients and family, then that has to be done. This particular person can't do everything in like a 1 hour. If we take 1 hour for each consultation, so you can't finish, or not even 1 hour, maybe half an hour. So that's where the time becomes pressure. And that's where the time management is the key. If it is like an OPD or the outpatient department, outpatient clinic, or anywhere else, we need to do what is needed. And that's where we need to develop skills to do that. And that's the checking is this exam. And now coming back to the time management for station 5, we all know it has got a 10 minutes for one BCC, brief clinical consultation, either 1 and 2. And when we talk about 2, be prepared to get anything first. So it won't be in the order of BCC 1 and BCC 2. You'll be given 2 scenarios at the same time. During the waiting time, like the 5 minutes is the crucial. I'll tell you in a minute about how we need to use widely the time. The time management comes there. The time management is not about how we ask. The time management comes there in terms of how do we prepare the session, that 5 minutes, how do we prepare? So in the 5 minutes, you'll be given 2 scenarios, BCC 1, BCC 2. I don't know which order, you'll get a 2 at the same time. So generally people think, okay, the first one is, for example, headache, and the second one is tremor. It can't be like that. It can be anything. So when you enter the room, the examiners will direct you, okay, go to this patient first, and that might be the patient with the tremor. So need to be very careful about where we are going and which patient we are starting the examination or our consultation actually. So that's one thing. And coming back to time management, maybe I can say this first. In terms of the first 5 minutes is the key. So when you say first 5 minutes, you're going to talk about 2 scenarios, and literally like a 2.5 minutes or 2.5 minutes are there. Even if you take like the 30 seconds out for it to go and get it and then sit down and have a look and things over there. So literally you've got exactly 2 minutes for each station to get the preparation. When you do the preparation, now there comes in terms of whether we need to take notes or not to take notes. So if you are taking notes, I would say we need to be very neat in terms of time management, because you don't have a time to take your notes and then have a look and then ask questions in terms of, okay, these are the questions I'm going to ask. Let's say, for example, tremor, the usual thing is like a duration we are not going to miss, and any peculiar questions in terms of etiology, what could be the tremor is due to. So if you get a tremor as a BCC1, literally speaking, there won't be any time to note it down and then look at the notes and then ask the patient the questions. So we can note it down to as like a checklist, and that's where the time management comes in play. So in terms of time management, when we note down the points we need to discuss in that particular station, BCC 1 or BCC 2, my suggestion is to note down only the peculiar things which we tend to miss or which we need to do it as a prompt, not like each and everything. So for example, tremor means not to write it down, duration, this and all. No need to. This is my suggestion. Because the time is the key. You don't have time to look at this. Rest of the things will be in our mind and then will be rehearsed properly. When I say rehearse, is a practice properly in terms of what are the key things need to be asked. Only 2 minutes. In the 2 minutes, we need to do a preparation for that, what we need to do, and then what are the key points to tell, peculiar ones, which we tend to miss. And when I say peculiar ones, so what are the peculiar ones and what do we do with the normal ones? The normal ones are, let's say, the duration, time, and it's a slow progression or fast progression. Any emergencies going on here, we need to exclude anything or any chronic problem. So these are all like a usual one. So don't try not to make it as notes and then say it. So this is the first 2 minutes per like a case, like BCC 1 or BCC 2. And in terms of the other thing is, how do we make, see, as I said, you will be given the paper with you. You can make a note, but literally you won't be able to see and then ask questions. Unlike the history taking, which is station 2, you can make a note, you can draw a diagram, like a 4 corners, and put a line in between, like a cross, anything you can do, like a flow chart, anything we can do. But in station 5, there won't be any time to do all those things. So people who are thinking in terms of writing notes in station 5, I would suggest to think about that and then say it may not work for this one. Okay, the next thing is about what are the key things which we need to practice, which we don't need to write it down. The first of all is the presenting complaints. We need to ask in terms of duration. Any complaint, start with the duration, unless it's given in the scenario. If the scenario is given, let's say shortness of breath for 1 week or so, no need to ask. We can confirm and things. And that's where the starting point is there. Duration will be the key. Give me 1 sec. I'll do this. Some glitch in the system. I'm so sorry for that. Right. Okay. Yeah. So that's the first thing in terms of duration. Any symptom, duration, and then progression, either acute or chronic. We need to ask. The next thing in terms of, we have to rule out emergencies related to that situation, exactly, whatever it is. See, let's say if it is a headache, we have to rule out all those things like a meningitis, a subarachnoid hemorrhage, and we need to take history based on that. So the key point here is emergencies. Any situation, we need to rule out emergencies related to that particular complaint. That we can note it down. If you didn't think about it, you can just note it down and you can just look at the glance. Okay, 1, 2, 3. If it's a headache, subarachnoid and meningitis. But all the things, whatever you are planning to do in the exam, we need to practice in real scenarios with our like a study partners. Because unless we do it, what we are going to do in the exam, it changes, and that's where the anxiety kicks in. Because if you're not practicing in terms of writing the notes and then seeing it and then telling, if you're practicing only on the day of the exam, you've never done that before, and the time is ticking and everything can go pear-shaped. So that's where whatever you are planning to do it, make a method which is suitable for you, and then fix a method and practice just whatever you're going to do in the exam. So coming back to the questions, yes, in terms of history taking, these are the things, mainly history taking for the station 5. We need to do what is what, yes, duration, and then acute or chronic, emergencies, we need to rule out all those things for sure. The next set of questions is like a standard question for any station or any case. What are those? Past medical history, allergy, medications, family history, personal history, in that smoking, alcohol, and there is anything like a travel history or anything pertaining to that particular case, plus occupation. So these things we have to mention whatever the scenario is. It could be chest pain, shortness of breath, vomiting, diarrhea, headache, visual disturbances, slurred speech, rash, joint pain, anything. We have to ask all these things. So this is where the time management comes. So these things is a standard one. So no need to write in the exam, like in those 2 minutes, all these things. No need to write. So we need to write only the peculiar things, not the normal standard things. So complaint, duration, acute or chronic, rule out emergencies, and the usual set of questions like past medical history, allergy, medications, family history, personal history, occupation, if at all needed travel history is a standard box. The third thing which comes in the time management is what are the things we need to, that when I say the peculiar things, and that's where, let's say you're dealing with patient with a dizziness and then you don't know what the cause is, or let's say seizure, then you have to ask about the driving. Just one line is enough. We have to ask about driving. And then if people say, for example, smoking, yes, I smoke 20 cigarettes per day. So no need to worry about the full counseling. It's not history taking station 2 to do the counseling. But you can just mention in terms of smoking, yes, I would like to advise to consider stop smoking, and there are helps available, and we can discuss if you want further another time. You can say another time, no need to do it at that point of time in terms of station 5. So that's the key points, because the situations which lead on to the peculiar things. So let's say somebody is having fever and you have to ask about travel history, about malaria and things. Definitely we can't miss that. And then the other things like the confidential things over there. So anything can come out. You need to be extra bit careful. So when it comes to the time management, the standard box things in terms of duration, acute, chronic, emergencies, and the list what I've told shouldn't be a problem at all. That needs to be well practiced and rehearsed any time. So no need to mention any notes or anything like that. The notes we can make in terms of the peculiar things, I would say, we can talk about the differential diagnosis and then not to miss anything. And even if the differentials in station 5, I don't think we would be able to discuss more than 3 ideally if we got one of those diagnoses right. If we didn't get one of those diagnoses right, we can extend up to 5. I don't think we will have time to discuss more than 5, because again, the time restriction there. With the examiner, it's only 2 minutes. So if we discuss the 10 differential diagnoses, examiner won't be interested and they will cut you short in the middle and then ask questions, because they have set of questions to ask. In this particular situation, this is the probable or the likely diagnosis, and then how we are going to investigate, how you already told the patient what it is likely to be and what are the investigation modes. So in those cases, it's not the time to show our MRCP Part 2 written knowledge to say there are plenty of diagnoses in there. What about this? What about that? Like a rare thing like a Gilbert syndrome and things and all. I don't think you need to know. See, this is not the time to discuss all these things. There are other stations, and we've already demonstrated our knowledge in Part 2 written and history taking sessions. You can like show our knowledge in terms of asking different things. So regarding station 5, what we need to do is we need at least 3 definite, and then maybe maximum 5. No need to worry about rest of the things in terms of differentials. We can exclude. The exclusion and the differentials will be coming in terms of the emergencies as well. So of the 5, let's say at least 1 or 2 should be an emergency. So now taking everything into consideration, the time management, this is we are talking about even before we are going to the station proper. The first 5 minutes, 2 minutes for one BCC, 2 minutes for the next BCC. In those 2 minutes, already practiced, rehearsed, no need to worry about the immediately, let's say the tremor means the immediate thing comes to your mind is Parkinson's, cerebellum, and then the third thing is benign essential tremor, thyroidoxicosis. That's all. So you need to be like that. See, tremor means that's it. 1, 2, 3, 4. These are the things. We need to bear that in mind. And then when you note it down, or it's up to you, I'm not saying we have to note it down, you can put it in the memory and then you can recollect over there. So that is the main thing in terms of the first 2 minutes for each BCC. Then going into the proper station. So how do you do in terms of time management? See, again, what we said about like a medical registrar job, and then the why the time is short, and then what do we need to discuss on all the over things and similar things. So you won't get, see, when you are a medical registrar, let's say the junior doctor will ask you to see this patient, and the junior doctor will give us like a summary or so. It won't be more than 2 minutes, because the junior doctor won't be telling all those things, and he won't be scanning all the notes in there. It will be like that. It's a real scenario. You won't get more than 2.5 minutes to go through a patient before you see the patient. And that's why it's like a 5 minutes for 2 BCC, like a 1 and 2. Coming into the session, you know what the diagnosis, likely diagnosis are, and then you know what are the emergency factors need to be ruled out, and you know the standard format is like a tape recorder, just on the button, on and on and on. No need to worry about practice many number of times these things. So till we have not touched about the examination part, I've told only about the history part. This is the one in terms of time management. Now coming back to enter the station. Okay, BCC 1. What do you do? How? Again, that's a big confusion for people. Do I need to examine first, or history and examination? How do I make the timing? With the timing, see, the 10 minutes is the full station time for 1 BCC, and of those 10 minutes, 2 minutes for the examiner. Don't steal that time. Don't ever steal the time, because we'll be in big trouble, because in the 2 minutes they've got set of questions to ask. Literally everyone, at least 3 or 4 questions they will have, and if we block them with our timing whether not to ask them questions, we are the losers, they are not the losers, because they will say only ask 2 questions, and then rest of the time they'll say that they didn't answer. So it's not like a not asked means not done, and something in the record keeping will say, isn't it? Once we have not documented, it's not done. That means similar thing in examiners. If we didn't give a chance to examiners to ask us questions, that means we have not answered the questions. That will be taken that way only. So the examiner part is 2 minutes. And then with the patient, 2 minutes. I would say, I will strongly suggest not to touch that 2 minutes as well, because that's where the patient concerns will be there. We have to ask what are the concerns, and what is it do you want. Again, you can ask what are the concerns, a straightforward question, but you can twist the language into say, so okay, tell me, do you have any questions? We can ask. And then do you want to ask anything from me? Anything like that. No need to be like exactly the word that, oh, you having any concerns at the moment. You can like whatever language we speak and whatever we are comfortable with in the framing the phrases, we can do it in our way. So the concerns is for 2 minutes. Whatever we are doing, like the history or examination middle part, as soon as the examiner say 2 minutes more or 6 minutes is gone, we need to be stopping everything or winding up just few seconds. You can finish the last sentence, not call abruptly. You can finish the last sentence and then close, and then come to the patient in terms of concerns. So now we are talking about the last 2 minutes with the examiners and the 2 minutes before with the patient or the surrogate. That means 4 minutes is gone completely. We have got only 6 minutes. So in that 6 minutes, again, people will be thinking in terms of how do I divide? Is it like a 50-50 or 40-60? And that again depends upon what is in the system. See, now only it will come into understanding in terms of what are the possible cases we can get in station 5. The theme, understand the theme. When I say cases, it's not about the symptoms or the problem, the theme. The first thing is acute problems. Any acute problems. The patient presented with headache, presented with vomiting. That may be acute problem which is not related to the background medical history. That's the first theme. The second theme is they've got chronic problems, but that's an acute exacerbation of the chronic problem in any other way, or the complications, anything. Let's say patient with rheumatoid arthritis comes with a joint pain. They have rheumatoid arthritis already, and then just exacerbation or anything, like an asthmatic patient comes with shortness of breath, COPD patient comes with chest pain, heart failure patient comes with the swollen legs getting worse. So anything, they have a problem and the symptoms are related to that problem. It's not completely new. This is the second set of the theme. And the third set of the theme, people have medical problems, people are having treatment, and the theme or the symptom is about the complications related to the treatment. Let's say somebody started on antihypertensive and then they become dizzy, postural hypotension is there unless we measure, and then they had a fall, they come here with the dizziness, fall and everything. Let's say confusion, the drug, somebody started on morphine, like a 10 milligrams of long-acting morphine twice daily, 2 days before, and then they become confused and then unable to concentrate and sleepiness and over there. So these are all related to the treatment what we're giving. So this is the main theme. 3 types actually. 1, acute problem which is not related to the background medical problem. 2, background medical problem related complications. 3, it's a medicine treatment and that's a treatment related complications. That is the theme. There can't be anything else. We can fit everything into that. What we don't get it is that completely new bigger problem and then 3 or 4 problems and 3 or 4 systems, we won't be getting it. This will be the theme. So in that case, again, in terms of how the time management, now we talked about the history. To get the time management right in terms of history, the first step I would suggest is we need to be very, very thorough with the station 2 history taking. Because once you know how to get the full history in 14 minutes, then it's easy to summarize and then get it there. I'm not saying don't do the preparation for station 5 unless you're ready for station 2. I'm not saying that, but do it parallel. But don't do station 5 without doing station 2 at all. I don't think it would be helpful practically because it's the same pattern. Same pattern. It's a long list and here is a short list of whatever we are asking in station 5. So do practice station 2 and station 5 at the same time and get it across. Coming to the examination, again, we all know we need to finish all the examination within 6 minutes, like ORS or CVS, respiratory, cardiovascular, neuro, or abdomen, anything within 6 minutes, and that 6 minutes covers everything. It's not about auscultation. We know that. So you're entering into the room, observing what is going on, and then anything under the, like a near the bed, or anything like a crutch, or like an inhaler, or anything, nebulizer machine, or anything like a pig feed, or anything. We need to have a clear cut in terms of this is outside. And then first look at the patient. We know in terms of observation, either a clubbing there, or the JBP is rise, is he short of breath, or slightly cyanosed, and then swollen leg, and then massive abdomen, jaundiced. Then only we need to talk about like the system examination. So again, when we can do all these things in 6 minutes, the examination part here in station 5 is a mini version of all those things. So well versed with do practice similar things. So don't do that. There isn't anything specific for station 5. So we need to borrow from that skills and put it here like a minimum needed skills over there. So that is the examination part. Now coming into the how to divide history, examination, there are different ways. There are plenty number of ways. We need to choose what is good for us and what we are comfortable with. Either we can start the history and then do the examination and then history and then the examination again, like a minimal part. We can do that. Or there are a variety of ways. People who can do both at the same time, you can do at the same time, history and examination. See, when people are doing history and examination at the same time, when you say examination, like looking at the clubbing and then looking at for a paler and things, you can ask in terms of, but if you do this, the first of all, the observation power or the skill, we need to improve drastically. See, it's not like asking. We need to remember that. And then we need to convey the message to the examiner. So whatever we are asking, there isn't any note station here. When I say note, there isn't any time to keep the notes and then putting and then talking to the examiner. So it's just like we need to remember everything. So in that case, yes, we can combine both, but we need to be developing or observing skills to the maximum as much as possible. And this holds to all the patients. And that's where we need to put that in our practice to say any patients, whatever I have told in terms of inspection. So not to do only for the exam, only for the practice. We need to do for every patient, whether it's relevant or not. It doesn't matter which specialty you are on. So from today onwards, from this time onwards, when you go there, just get into the habit of seeing everything around the situation and next to the patient and in the patient observation. Then you can see what's going on. So this is about, like in communication skill station, the body language, observing the body language and what they are, what they are at, and we need to think in terms of restless, agitation. So all these things, all observing skills we need to do in terms of what is going on. That's the first thing. And now coming back to whichever combination, history, examination, I can say focus history, focus examination, then catch up what we have left in the history, then catch up what we have left in the examination, then stop at 6 minutes when examiner says patient concern, and then go on to the examiner. This is, we can practice this way. And when we say history and then catch up history, what I would suggest, which works for most of the people, which I've told, so it's like a 2 minutes for the history, and then next 2 minutes for the examination, and 1 minute for the history catch up things, and the last 1 minute for the examination, whatever we have left. So it doesn't need to be this much. We are not going to time again. People ask me in terms of, can we do the timer or can we take the digital clock and things? I don't think it would be allowed, and I don't think you will get time to even see all those things. That's what I said. It's a second nature. It's just a practice. See, just like what we talk every day, it won't be like there is no time to look at the digital clock and on and off. There won't be any time. So the way we do is by practice. So we need to practice with our own sentences, with our own speed, and then time it, and then we know what is in there. Like the one I said in terms of all the other bits, like past medical history, personal history, and then family history, occupation. These are the 4 things. So we need to time, and we will do some scenarios after this. And in that we will time, and then we'll see how it would be helpful to time it. And okay, this much will take like 30 seconds or 45 seconds over there. And like the similar thing in system review in history station. So you need to time, or else you will go everywhere and then you don't get any time in there. So we need to time in that one as well. So this is where we need to get time. And when you get time, you know exactly what to be done and what not to be done. And if you miss anything, suddenly a thing will come, okay, oh dear, I missed this. Then you can go back and ask about history. And similar thing with the examination. So it's very rare you need to examine 2 full systems. I'm not saying, for example, listening to the chest and then looking at the swollen legs. You can't say as a 2 examination. It's not 2 system. See, examining the swollen legs, if anybody coming with the shortness of breath or chest pain, if you are thinking in terms of cardiac, is mandatory. That's not additional. We are not doing additional. So we are going to do only 1 system. Either do with the general and then go to the quick system, or do the quick system and then catch up with the general or other salient points. So in those cases, I would suggest the first 2 minutes for quick examination, and then the last 1 minute if we miss anything or anything over there. So if we go too much, the examiner will stop you. See, for example, let's say the headache is there, and then clinically it sounds like a stress headache, but still you need to offer like a fundus examination. You would say, if you go and touch the fundus and ophthalmoscope, examiner will say, no need to worry, fundus is normal. Either they will say the findings, fundus is normal, or they will say, no need to worry about it, no need to do it. So the reason I'm telling you is this: if you're planning about a neuro exam, and then I don't think they will expect you to have the neuro exam plus the fundus plus the general examination. It can't be there. The reason I'm telling this is, that's what I'm telling, if we know about the full examination, we can squeeze that into mini examination and see what is going on. So that is where we need to time it. So 2 minutes history, 2 minutes examination, 1 minute history to catch up things whatever we have missed, 1 minute examination to catch up things whatever we have missed, and then 2 minutes with the patient concerns and explaining what we're going to do. Usually patients will have 2 questions, at least 2 questions, and just don't try to explain longer and longer and longer because you will miss the second question. If people ask, can I go home and is it something serious, means don't explain, can I go home, with all the thing we know, and that's because there isn't time. So literally it's the 2 minutes with the concerns, means like maybe 45 seconds, that's it. Just the examination, the examination findings and things. If you have anything to tell, you can say, this is what we found, this is what the probable diagnosis, we need to investigate and we need to do. Their questions invariably will be like, is it something major, or is it something, can I go home, and what's going on, something like that. There won't be anything about. See, that's what the usual, if we go to the hospital as a patient, and we will ask the same, isn't it? So what's going on? So don't worry about what other questions would be from the patient. It's a standard box questions. They can't ask anything we don't know. It's exactly we know, and that's what we're doing all along. That's a concern for 2 minutes. The last one, examiner 2 minutes. Again, I've told it before. They have a set of questions to ask. Don't jump on the questions. Don't answer. See, don't leave step by step. In terms of, for example, what to say, step by step, or the questions. See, somebody asks you in terms about well score. Okay. Examiner is asking, okay, do you do anything for assessment for DVT? Then the answer would be well score. Okay, then the examiner will ask, okay, what do you do with the well score? And then you need to tell management. Then the examiner will ask, okay, what do you do? How do you choose? Either enoxaparin or oral anticoagulants? No, this is not the way, because there isn't time. If the examiner is getting into not bored, if it's getting, see, we need to tell everything quick. 1, 2, 3, 4, like that. So in that case, if the examiner, if you're telling it, you can tell in terms of, this is what I manage. So I'm thinking in terms of a left-sided DVT here based on my history and examination, and then I would like to do these things, and before that I would do the risk assessment using well score, and depending upon the score I would do the test, and if it comes positive I would do the examination. So I'm not if it's positive I will do the treatment. So I'm not saying you need to do everything together without giving chance to examiner, but not to go in staggered step. It's not like examiner won't have patience and won't have time. Patience is a wrong word. They won't have time to probe you and then ask many things. So we need to clearly answer the question. That itself is a separate discussion in terms of presentation skills to the exam. That's also the key in all the stations, particularly in station 5. So within 2 minutes, we need to tell exactly what we know and answer what the queries. So this is what I think in terms of time management. It starts from preparation before going to the station. 2 minutes for each station. Standard box things, don't write it down. Don't get into the habit of writing down and then seeing and presenting early. If you are doing it, do practice with a timer with your study partner, then you will know whether it's right or wrong, whether it suits you or not, rather than right or wrong. If it suits you, you're welcome. Then coming back to the examination skills, like a 2 minutes plus 2 minutes history examination, 1 minute history examination, 6 minutes gone, 2 minutes patient concern, 2 minutes examiners. Now people can ask, what I can do history and examination at the same time. So how can I time? Very well. No need to worry about it. As I said, you need to do. See, when you say history and examination, you need to time that as well. In terms of what do you mean by examination? Are you talking about the observation skills, general examination? Or are you talking about, see, nobody, I can say nobody, but some people can challenge me, no, I can do it. See, when I say nobody can listen to the patient's heart and then ask questions at the same time. It won't match. But you can look at the nails, and then when you look at the clubbing, just fraction of a second. See, when you say clubbing, don't do all these things in station 5. Is there or not? If it's not there, likely to be. That's all. It looks like. If you're not sure, you can say looks like, it seems to be. And don't do all these tests and all, and there won't be any time. If it's there, clubbing, or not there. If you're sure, tell it's clubbing. If you're not sure, you say it looks like clubbing. They're not going to fail you because you didn't pick up clubbing and you said it seems to be. But if you miss, they will mark you down. So in that case, what to tell, that's a complete another thing to discuss in terms of how to present to the examiner within those, like a sleek presentation within 2 minutes. So this is how I would see as a time management. Before we going on to the discussion proper, any questions, any modes, either I can ask or that I can chat or anything. There's already one chat. It says a very good tip, sir. Thank you. Right. Okay. Then we'll proceed on the case discussions. So when we come to the case discussions, and we can do some role plays. When we do role plays, the timing is important. When I talk about the timing, what I suggest is 6 minutes. I can give the time. I'll give a symptom, and then and before that, whether it's a discussion or the role play, is anyone willing to do the role play? We'll ask the question. Anyone willing to do the role play?
Can you do it, doctor?
Yes, sir.
Sorry, who is that?
Raj.
Yes, sir. I'm Shaheen.
Yeah, you are, and some other person. Sorry, I got answer from two people. Who's the next person? Hello? Right, who else want to do? Dr. Shaheen is there. Who's the other doctor?
Raj, Dr. Raj.
Dr. Raj. Okay, right. So we can go, we can alternate and then see how things go. So the first thing, I'll explain the timing in terms of, say I will give you 6 minutes. And before 6 minutes, I'll give you 2 minutes to preparation time because we need to do it as a proper exam, 2 minutes, or even I can give 2.5 minutes. I'll tell the scenario. I'm not going to write it down. I'll tell the scenario and then 2.5 minutes, cut you there, and the session starts. 6 minutes for history and examination. Then I will stop you at the 6 minutes. 2 minutes patient concerns, and then 2 minutes with the examiner. That's what the timing is. And within the 6 minutes, I would like to tell one other key factor for examination. So if you ask in terms of, I'm looking at the legs, I will tell whether it's swollen or not, because virtual, I'm not having patient in front of me. But at the same time, if you ask, I'm listening to his chest, I'm not going to tell immediately no crackles or wheeze. I'm not going to tell immediately because it is time consuming. You're not going to get, when you put the step on, next second you are going to get the answer. So remember that when we practice virtually or anyone with your study partner, we need to do exactly the same thing what we expect in the exam. So if you are asking about, for example, thyroid swelling examination, I'm not going to tell you what is in the neck. If you ask me, I'm not going to tell you there is a swelling and it moves. It takes time. So when you ask me in terms of examination, what's going on, I won't answer immediately. The simple things I will answer. If you say any jaundice, I will say yes, icteric. That's straightforward. But if you ask in terms of examination, if you say what is the power, I'm not going to tell you 4 out of 5. I'll leave some time, like 20-30 seconds, and then I will tell you what is going on. So remember that. And so that's where I would say like a 6 minutes. You can mix anything. You can ask even first itself, you can ask what the exam. I'm not going to tell you which one to, because we would have practiced everything, and your way is your way. So no need to follow my suggestions or whatever I tell you in terms of time. I'm just giving you a guide. It may not work for everyone, but you need to choose what the best you are at. So we can go through the scenarios, and maybe Dr. Shaheen, you can go on first. Is that okay?
And sir, your tips are very great. I thank you so much for that. You told so great tips today. Thank you so much.
Thank you. Right. Okay. So I would say when the session is going on, say it's not like a role play. I would say maybe something like a mock exam. So the reason I'm telling is, even though you know the answer or if you know something is going wrong, I'm talking to the other people who are listeners, please don't put anything in the chat. That will distract the person who's doing the session. So we do it as a clear mock here, and then we will discuss about. We've got like 1 hour and 10 minutes there, so we've got plenty of time. We can discuss at least three, I guess, depending upon how people are doing it, and then we will start. Okay, so the timing is important here, as I said. Okay, the timer, and then first I will do 2 minutes and 30 seconds. If people want to put the scenario in the chat, you can, but I'm going to tell the scenario only. Right, 29-year-old. Okay, I'll note it down for myself as well. Just a minute. Right, 29-year-old Rosie, and she came to emergency assessment unit with swollen leg, left side. Okay, 29, female, Rosie, EAU, emergency assessment unit, swollen leg, left side, and your time starts now, 2:30. So people who are listening, I would say make it as a normal, like a mock exam, and then just note them somewhere in the paper or in the notes section of the phone, anywhere else. So collect your thoughts, and then as I told in terms of taking into the situation, it's a very common situation, swelling left leg, left side, and then we'll see how things go. And when the time is over, I'll be very, very strict with the timings. I'm telling you, whoever is doing the role play, because I'm having said about the time management session, if I'm not strict, there's no purpose. Let's see what's going on here. Right, for the doctor who joined now, I'm just telling you we're doing like a mock exam kind of thing, station 5. So please don't make any comments or anything in the chat until the station is over. It will distract the candidate. Right, time is up. The time starts now for the 6 minutes.
Hello, good morning.
Hello, good morning.
I'm Dr. Baik, one of the doctors in emergency. May I confirm you're Miss Rose, 29 years old?
Yeah,
We are here to discuss about your problem and I will examine you. Is that fine?
yeah.
You came with problem of swollen leg on left side. Please tell me more about it.
I've got a swollen leg for nearly a week now, and it's very painful. And it's getting worse in the last week, and let's say it's worse from yesterday.
Right. Is this involving whole leg or half of the leg?
It's only the leg below the knee.
I want to see the patient leg also along with it. Okay. Any, you said pain, any redness?
Right.
Any
Any
redness?
redness? Yes. When you examine, there is a redness.
Okay. In the knee, below the knee. Okay. And the pain, you said how much from 1 to 10 you will grade it?
I would say 7 out of 10.
Okay, it started suddenly or gradually over 1 week?
It came on sudden but got worse gradually.
It is moving anywhere, the pain in the back of the in the legs or in the up behind the back?
No.
Anything making it worse, like movement, exercise?
Yeah, when I move, it's worse. Yeah.
Anything making better?
I've just taken paracetamol and a little bit better, but not much, and that's why I'm here.
Okay, right. Apart from this, do you have high temperature?
High temperature, no.
Any weight changes?
No.
Any rash?
No.
Any trauma?
No.
Okay. Any lumps or bumps?
No.
Any joint pains?
No.
Okay. Any past history of note I should be aware of?
I'm a diabetic.
Since how
Type
long about it?
1.
Since how long?
Well, since the age of 10 years, actually.
And what are you taking for it?
Humulin M3 insulin, 10 units in the morning and 10 units at night.
How is your control? How was your last hemoglobin A1C?
I don't look with the HbA1 hemoglobin A1C, but I'm fine with it. GP said everything is fine, so no need to worry about it.
Okay. Right. How are your water works?
They're fine.
Any color change or any pain?
Color change, pain, no.
Okay. Any vision problem?
No.
Okay. May I know any chest pain?
No.
Any shortness of breath?
No.
Okay. Miss Rose, I will ask some further questions, sensitive. Are you taking any birth control pills?
No.
Okay. And are you in long-term relationship?
No.
Okay. Right. Apart from this, do you have any anyone told you look pale than before?
No.
Yeah, I want to examine the patient now. I want to check the legs. Is it swollen and red? You said. I
Yeah,
want to check
left leg below knee, swollen and red and shiny.
any recent infection or any injury to any part of the body.
No.
Any recent throat infection or any tummy upset.
No.
Any back pain.
No.
Any loss of control of water work or bowel work.
No.
Okay, I will check the hands, sir, for any rheumatoid changes, and the pulse I will check.
Hands normal, pulse normal.
Okay, I will check the chest for any PE, any loud P2,
So you want only the loud P2?
and the murmur, any murmur. And I
Right.
want to check.
You got to wait for 30 seconds and then I will tell you whether it's there or not.
Just sir, on the pulmonary area and the cleft.
Wait. Yeah, chest is normal.
Okay, sir, I will check for ruptures, breakers, cyst now in the legs. Is it on the back of the leg or on the whole of the below the knee? You said. And the
Whole of the,
temperature.
no, not in the popliteal area. It's whole of the below the knee.
Okay, I will touch and check for temperature.
Temperature normal.
So you said popliteal area, right?
I said not popliteal area.
Yes. I will check pulse.
Pulse I've done already. Normal.
Dorsalis medius. And any numbness or weakness in the legs.
Is it examination or history?
I asking, sir, any numbness or weakness in the legs?
History, no.
Okay. Do you smoke?
Yeah.
How much? For how long?
10 cigarettes per day for nearly 10 years now.
I would advise to quit smoking and we can help you. Do you drink alcohol?
No.
Do you take any medicines?
Time is up. We've got 2 minutes more with the
Okay.
patient.
Okay. Any medicines you take?
I know, other than paracetamol, I don't take any. As I told, the insulin is there.
Okay. What are your concerns?
I don't know what's going on. What do you think is going on? Because people are scaring me to the level core about this swelling because I'm young and 29. So I want to know what is it? Is it something serious?
Yes, Miss Rose. Before that, any history of travel
No,
recently? Any surgery, hospitalization?
no.
Okay, Miss Rose. After examining you, I think that you are suffering from a condition which is a deep vein thrombosis. It is a disorder in which the blood in the legs become thick and clot, and this condition can be fatal if it dislodges and travel in any other part, especially the heart. So we will do some investigations in the form of blood test and imaging, the scan of your leg, and we will form multidisciplinary team of doctors to look into these. We will start you on some blood thinners to prevent this clot from dislodging anywhere, and I would like to admit you for this.
Okay. So you said it's going to be fatal, isn't it? So if that's serious. That's serious, and that's what people telling me. I don't know what I'm going to tell you. You said, when am I going to die? You said it's fatal, isn't it?
Miss Rose, it can be a serious condition if not treated because the blood clot in the leg can dislodge anywhere. So we will do some scans to confirm our diagnosis.
Okay. Right. So you said about admission here. I don't. Can I go home and then come back?
May I ask any problem you can share? We can help you because you need to admit.
Okay. Right. Thank you. 2 minutes with the examiner. So what are the differential diagnosis here?
So my first differential for this lady is deep vein thrombosis. Although she didn't give any history of long flight or surgery or OCPs, but I will keep this as a differential. And secondly, it could be a ruptured Baker's cyst, although there was nothing on the popliteal fossa, but I need to rule out. And thirdly, it could be cellulitis, although she had no fever, but it is a possibility. And fourth, it could be any trauma.
So what do you do?
I will do some investigations. First of all, the blood test to see the clotting profile, especially for PT and APTT and CBC, ESR, CRP for any infection. I will go for ultrasound Doppler of the legs first and D dimers. And if they are positive, I might go for CTPA, although she has no problem of shortness of breath. But first of all, the ultrasound Doppler and D dimers will be my investigation.
Do you do ultrasound Doppler and D dimer at the same time?
No, sir, we will do well score for this patient. I think we will go for ultrasound Doppler of the legs, as she has high probability of DVT.
Okay. What are the clinical features of pulmonary embolism?
The pulmonary embolism can manifest, the chest will be clear on auscultation, but she can be tachypnic, tachycardic, and on ECG we can get S1QT, S1Q3, S1Q3 T3 pattern, but it's not always present. Otherwise, the chest is always not significant. And
What's
we
the
can get
definitive investigation for PE?
definitive is CTPA, and if she is like pregnant, we can go for VQ scan.
Right. Thank you. Time's up. Right. Okay. Now, any reflection from your side, first of all, and then we'll ask people, then I'll tell you.
No, sir, you can tell me.
Okay. So do you think in terms of time, when I ask about the time, you came to the examination bit only in the last 130 minutes. So you took history for 4.5 minutes, and then you took the examination only for 1.5 minutes. So that needs to be adjusted a little bit, I would say. Okay? So because examination, you can't be that quick in terms of examining, because even though you said in terms of low P2 and things, some of the systems will take time, so you can't do that. And the redness, you say again, when we know exactly the redness on examination, you can cut that question from the history.
Hmm.
You're you're going to see, isn't it? Whether it's red or not, you're going to see. So in that,
Tender or
if possible, you can cut it down. And then again, tender pain is different over there. See, I would say you asked lots and lots of questions, and then that was too quick, I would say. So first itself the swelling left side is below the knee, and then a pain, sudden gradual moving to the back, increase in movement exercise, and then increased temperature, weight changes, rash. Why did you ask rash?
sir, just connective tissue disorder, anything?
For swelling, unilateral swelling.
No, sir. It was a like general question.
General question is need not be taken in station 5. Okay, no, I don't think you need to ask about rash here. Weight changes, why do you ask?
Okay. Therefore, rule out any malignancy can cause unilateral lymphedema.
That's again, it's as I told, the DD is not malignant. In the DD, you didn't tell about malignancy. Whatever the differential diagnosis, we need to focus on the history. If that's not in the differential diagnosis, no need to ask about. And similar thing about lumps and bumps as well. I don't think it's completely relevant in this situation. A patient with no past medical history other than type 1 diabetes mellitus and very young, we are not going to talk about malignancy or here over there.
Right.
What did you ask? Waterworks, color change, pain. Why?
So for diabetic, ruling out complications.
Again, the main problem is swollen leg. No need to go. See, that's what I said. Like two system, two problem. It's not in station 5. It's unlikely. So they're not going to talk about the poorly controlled diabetes and DVT. It's not going to happen. So no need to ask more. Vision. Why do you ask vision?
The same diabetic.
No, I wouldn't say the diabetes is just like a past medical. So if you are thinking in terms of diabetes causing the that's what I said. The theme is clear. New problem, disease related problem, treatment related problem. Focus that mind. That's easy. See, if nothing is there, rash, weight changes, lumps and bumps, vision comes under anything. So that's why you spend nearly 4 minutes to get the history. And then you repeat it again with, for example, like a bowel, bladder, and all, and any infection in the throat. Why did you ask infection in the throat?
So to rule out cellulitis, any infection anywhere in the body.
Any infection in there. Okay. Right. And then you ask about numbness or weakness in the legs. Why?
So first of all, diabetes I was ruling out, and secondly, because of cellulitis, patient can get DVT or cellulitis can cause numbness if severe.
Again, I don't think it's completely relevant here. See, we are not going to see if you got time only to describe about cellulitis, you can ask in depth. See, in cellulitis, what we need to do here is it is a red, swollen, shiny, tender, and then clear cut unilateral with the marking everything. That means cellulitis, unless put otherwise. Check the blood and then do it. If it's going to be numb, are you going to change the management? If it's not going to be numb, are you going to change the management? You're not, isn't it? So in that case, I don't go into depth and getting into problems because the time is the biggest issue. So in history station, yes. In examination station, yes, but not here, I would say. Okay, that's with the history. So if we cut all those things, you'll be clear cut looking at not 4 minutes and 30 seconds, you'll be coming down. And examination, weight, another like a general history, you asked about travel, surgery, hospitalization, smoking, alcohol. You didn't ask about family history, did you?
No, sir.
Yeah, that's important. And the past medical history, yes, you asked any past medical history, but if you're keen in terms of here, you can ask about past medical history of blood clots
Mm. Yes, sir.
specifically. And that's what I said, like the standard box one and the peculiar one. These are the peculiar ones here in terms of the family history and then the blood clots, anything in the family and things. That plays a major role. And you said history of trauma, that's fine. And then such as a PE, that's fine. And if you get time, you could have asked in terms of contraindications for anticoagulation, any reason bleeding or anything. That makes things more complicated when you choose anticoagulant. So in terms of treatment, you diagnose DVT. That's clinically is a DVT, and then the diagnosis is there. You did ask about pills, but you forgot about pregnancy.
The time
Again,
was not allowing me. I was asking, but then time finished. Yeah. Pregnancy.
again,
Yeah.
see, time, see, you can say, I didn't ask about the rash and joint pain and lumps and bumps and the weight changes because there is no time. But we are not allowed to say, I didn't ask about pregnancy because I lack time, because that's the key here. See, being pregnant is going to help more in this situation of DVT rather than rash or anything. And that's where we need to prioritize and then look into it. Okay? And then you said about well score and examination. You said yeah, blood thinning admissions. And again, DVT. You said DVT. Did you say clot in the leg? Oh, sorry, clot in the legs.
I explained her. After DVT, I said it is a condition in which blood clots and thickens in the leg. I told her.
Yeah, but again, I wouldn't have said about the fatal complications immediately. And it's just like, see, again, the clinical communication skill spot here. If you say anything strong, if you say anything over there, there need to be a pause, there need to be see again the breaking bad news rule exactly the same. And if anything, you're talking about okay, this is very serious, very dangerous, and then just a few seconds, wait. But what you have said is okay, DPT is a disorder of the clot and it could be fatal, can go to the heart, and then we need to do the scan, we need the MDT, and then we need to give blood thinners and we admit. That in my opinion, that is not allowed. You need to break it and then see one, 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 one. It's like a to and fro, to and fro, to and fro discussion. But because you're running out of time, you need to hurry everything. And that's where I would say the first thing first is get the time right, and then you won't need to get hurry all the time. And your DD, yes, is right. DBT, cellulitis, trauma, ruptured Baker's is all are fine. And then you told about well score, but you didn't see. We don't do Doppler and D dimer at the same time. Have a check on that. See, if the well score is extremely high, we'll go for straight away Doppler. If the well score is a little bit on the off side, we can go like a D dimer and then either rule in or rule out. Check on that, but not to do everything in there. And then I'm not sure about ESR here. And then you said CBC, complete blood count. I would avoid the short form anywhere in the exam, either history or examination or anywhere. If you are going to talk anything like that, no need to talk anything with the short form.
Okay, sir. I have two questions. Can I ask?
Yeah.
You need to mention CBC or not, first of all? Because of cellulitis, I was ruling out infection. CBC. So we need to mention in station 5, or just I should say the ultrasound Doppler or D dimers, like after well score.
No, the
Straight away.
bloods, the basic bloods you have to do it, whether it's a DVT or not, you have to do it.
But CBC, you saying not to tell the short form, right? Complete blood count is the.
Yep.
Okay. And so second, the
Complete
DVT.
blood count here again for the people who are going to take exam here in UK, they won't say CBC, they will say FBC, full blood count. So don't
And
use
so
the word CBC here if you're taking in UK.
And clotting, I need to do clotting also, right? The PTA, PTT. So I will say clotting profile. That's enough.
Yeah, that's enough. Clotting profile is enough.
And the thrombophilia screen I can add in it. And so
Yeah, again,
second thing,
if you tell too much, there won't be any time. So thrombophilia screen things, so you can do it. The young patient, we need to, what do you want to exclude the thrombophilia screen here in this case?
just one word I will say thrombophilia screen to rule out factor 5 or any hereditary cause of blood clot.
Yeah, you can say, but if you have time, you can. But I don't think you will have time to do that.
And so my second question is, in DVT, we need to tell the patient that you have deep vein thrombosis, or just tell that you have a clotting in the legs.
See, clot in the leg is easy rather than DVT.
So we need to mention this word to the patient or no need? Like some mentors say you need to mention what is the disease to that patient.
No need. Why? Why
Okay.
do they need to know?
The patient concerned. So what is this disease? So I will say it
No,
is
no.
a clot.
I didn't ask you what is the disease. I'm not going to ask you etiology, pathology, and all, isn't it? Wow. As a patient, I just want to know what's the problem. That's all. So if you say clot, that's okay. You can add in terms of, okay, the clot in the lung, we call as a DVT. I don't think it's completely relevant here, but depending upon the patient. If the patient insists on what is the medical term, then you can say.
Okay.
If not, I don't think there's need to say. Clot in the lung is enough. Sorry, clot in the leg is enough.
Right. And sir, in pulmonary embolism, what will we get on the chest? Am I right, or if anything we will get?
Right, but we need to be methodical. See, you straight away went into loud P2 and chest clear and things. So what about JVP and things? It depends upon, isn't it? So you need to start from there. See, anything examination starts from like a general inspection, key findings. I'm not telling you no swelling, is no, not sinus and not like that. But the key features you need to ask.
Okay, sir. Thank you so much.
Right. Okay. Now, any questions from anyone before we move on to the next one? Anyone? And is Dr. Raj ready for the next one?
Yeah.
Okay. Right. I will make a note. Right. 60-year-old Graham Thomas come to gastroenterology clinic with loose stools. 60-year-old Graham Thomas came to gastroenterology clinic with loose stools. Your 2.5 minutes starts now. The same thing for people who are listening. Just work out in terms of differentials or make a note. I'm not sure whether you are making notes and things, but that would be helpful. And then get into the groove and start doing. Then it's easy. So if all the most important thing is we need a people like a study partner or a mentor or anyone to time it and in a crude word drill people like this actually, then it's easy. If you know what to do it can be done easily. Right, time is up, and your time for 6 minutes starts now.
Hello, hi, I'm Dr. Raj, one of the doctors working in the clinic today. Is this Mr. Thomas, 60 years old?
Yep,
Mr. Thomas, I can see from your notes that you've been suffering from some loose stools. Is that right?
yep.
Can you tell me more about this?
Yeah, I'm having this like a diarrhea for 3 weeks now. So it was like started on and off, and then initially, let's say 2 days, two times a day. Sorry, I'm mixing up with the days and time actually because it's terrible. So 2 times a day, and now it's nearly 4 to 5 times a day actually. So I'm finding it very hard to do everything.
Okay, so Thomas, can you tell me, is this the first time you've been having these loose stools or have it previously?
No, this is the first time.
Do you think this started all of a sudden? Was it gradual?
Started sudden, but it got worse.
And I understand that it's worsening over time now, right?
Yep.
And have you noticed anything making it worse? Like any diet in particular, any diet you're taking that is making it worse?
I don't think so.
Okay, anything making it better?
Not really. I wish something will.
Okay. Do you think you are waking up in the middle of the night to go for loose stools?
Yeah.
Okay. And have you noticed along with that in loose stool any blood in the stools?
Oh no.
Any mucus?
No.
Are they pale?
So what is that?
Are they pale? Pale in color?
Pale.
Yeah.
Pale in color. No.
Are they like ordery, like offensive, ordery?
No.
Do you think they're difficult to discharge?
Difficult to discharge.
Yeah, I mean difficult to. Are they floating in the plan?
No.
Okay. Any like feeling sick or throwing up?
No.
Any early fullness after meals?
Sorry, your voice is echoing. What is that? Second one?
Any early fullness after meals?
Heavy fullness after meals. No.
Any swallowing difficulties?
No.
Any heartburn?
No.
Any tummy pain?
Slightly, not much. So once
Uh,
in a while, get a tummy pain
where exactly?
in the middle of the tummy.
Okay, is it radiating to anywhere else?
No.
Okay, on a scale of 1 to 10, how much would you rate?
Maybe 4 out of
Okay.
10. Yeah.
Any yellowness of your white part of your eye?
No.
Any fevers?
No.
What about your appetite?
Fine.
And what about your diet?
Fine.
Do you think you're paler nowadays?
No, not really.
Any racing of your heart?
No.
Past medical illness and to be aware of?
I'm a COPD,
Okay.
and that's an ongoing story. Like I'm on COPD for nearly 20 years now. So
Okay.
it's on and off, and going to the hospital is just like going to friend's house. Just
Okay.
go, come back like that.
I can understand that. So, what medications are you taking currently?
I have only the inhalers and then a bit of steroids, prednisolone 5 milligrams.
Any over-the-counter medications?
No.
And prednisolone since how long?
Oh, that's about nearly
Okay.
5 years, 10 years. Yeah.
Any allergies?
No.
Any recent illnesses or fever? Or have you taken any antibiotics recently?
Yeah, all the time antibiotics. I live on antibiotics actually.
When was the last one?
Amoxicillin.
And when did you take the last one?
Uh, 4 weeks ago.
Okay, right. And what do you do for a living?
I'm a teacher.
Do you smoke?
No.
Do you drink alcohol?
No.
Any family history of cancers?
No.
Did you travel anywhere recently?
So what is that?
Did you travel anywhere recently?
Travel. No.
Can I examine you?
Yeah.
I would like to look at the pulse of the patient, looking for any sinus tachycardia or
100. Pulse 100.
okay. I would like to look at the eyes for looking at anemia or jaundice.
Not anemic, not jaundiced.
We'll ask the patient to open his mouth, look for any dehydration.
There are signs of dehydration.
Okay. I will look for the JVP, any raised JVP or anything.
Normal.
I'll come to the tummy and do palpation first to look at any organomegaly.
Normal.
I will do, okay. I will look at the legs for any swelling.
Normal.
Okay. All right. Okay. So, right. So what are your concerns, Mr. Thomas?
I don't know why I'm having loose stools. It's affecting me everywhere, every day. So I don't know what's happening.
Okay. So, Ms. Thomas, I can understand your concern that you're really concerned about the loose stools and it has been increasing in, and it is increasing day by day. One of the probable causes, I think, is because you have been taking antibiotics for a pretty long time. Is that right? So
Yeah.
it could be one of the causes that can destroy the normal flora of the, lining of the stomach.
2 minutes more with the patient.
It can
Yep.
it can destroy the normal lining of the stomach. All
Yeah.
right. So when patients take on a long time, it can actually destroy, and sometimes patient can have diarrhea like this. That is, I think, most probably one of the reason is that. But we also need to look out for other reasons why you might be having this. For that, we'll do some simple basic investigations. Okay. And I will arrange a meeting again to discuss the results about that with you. In the meantime, I would advise you to stop those antibiotics for the moment. Is that okay with you?
If you stop antibiotic, the COPD will get worse, isn't it?
So are you taking these antibiotics for the COPD?
Yeah, chest infection. I'm not taking it now, but I had it like 4 weeks ago.
So
But I've got a crisis pack at home, so whenever I feel a little bit odd with the breathing difficult, I just take on myself.
in that case, we can give you some other antibiotics which might not affect your gut. Is that okay?
Oh, that's a good news.
Do you have any other concerns for me?
Uh, is it infective? Is it infection?
It's not. It is kind of infection, but it is treatable.
Will it spread to other people?
That's a very good question, Mr. Thomas. Actually, it can spread to other people, and you need to maintain your hygiene, okay? And you need to use separate towels for yourself, okay? And it can actually spread to other people.
So I can go home, isn't it?
You can go home. We'll give you some. We'll do some blood investigations, and you can go home, and we'll call you back for review. Is that okay with you?
Yeah,
And I will also refer to the gut doctor as well. Is that okay?
yeah, that's fine.
Do you have any other questions for me?
No, it's a kind of explains. So I was a bit worried about the antibiotic, but you said we could do something different, isn't it? So in that case, I won't be having any problems. I'm okay with that. Time is up. Examiner time. What's the diagnosis?
Given the history of the patient and the examination, I think most probable diagnosis in this case is infection secondary to Clostridium difficile. Like he has taken antibiotics, long-term antibiotics. It could be Clostridium difficile infections.
Right. What are the differentials here?
It could be IBD, considering the age, or any sort of malabsorptions,
Yeah.
and it could be underlying cancer as well because he's a 60 years old man. And because he doesn't have any features of malignancy, however, I would like to rule out the cancer, but this is my last one of my differential diagnosis here.
Okay. And when you say malabsorption, what are the reasons?
Because he has been taking antibiotics for a long time. So I think it could be one of the reasons as well. And he has been taking some steroids as well.
Okay. Right. How do you investigate?
I would like to do CBP to look for any signs of infection, ES or CRP, and I would like to do a stool culture and sensitivity. I would like to do in occult blood as well.
Right. So I told, see, you've seen the signs of dehydration. So how do you manage?
So I would like to give him some IV fluids as well initially, and because he's dehydrated. I can treat him in an emergency unit, give him some dehydrations, and do some blood investigations, and get him back for review of the investigations.
But you've just said the patient can go home.
Yeah, I would reconsider my thing to to treat him in the emergency department, maybe.
Okay, thank you. Time's up. Right. Okay. Right. Any questions from you?
Not at the moment.
Right. It's quite good, I would say. It's good. So literally covered most of the things actually. I think it's for section 5, it's a clear pass, I would say. And yes, in terms of duration, the first question was very good. First time or previous, and then also about sudden, gradual, and diet. Anything better? Nighttime. I guess that's for nighttime is for
Yeah, I mean organic causes.
organic. Yeah, IBS. Yeah, to rule out irritable bowel syndrome. Yep. And then blood mucus, pale, odor. Odor, I think malodorous is a good word in terms of malodorous rather than odor or any difficult smell or anything. Kind of difficult to flush, you said discharge, but anyway, it's okay. Not a big thing. And heaviness or fullness, nausea, vomiting, swallowing, heartburn, abdominal pain. I said middle. And then you asked about radiation, jaundice, fever. I'm just telling again because if people miss it, they'll know what thinking behind all those questions. Appetite, diet, paler you asked twice, so maybe no need to. You asked about palpitation, second is to COPD, medications, allergy, over-the-counter, recent antibiotic, and that's where you got the clue at the end. If you didn't ask about recent antibiotics or recent medications, then it'd be completely off. You need to be a differential diagnosis. And that's where these things are I call like a key things actually. Key things, that's where I would be thinking in terms of. And again, yeah, in examination, yeah, anemia, jaundice, signs of dehydration. Be careful in terms of signs of dehydration. Anything, nausea, vomiting, diarrhea, we have to look at it. Like fold skin and then skin turgor and capillary refill and all, we have to do it quickly. Tuck. And you were well on time. I'd say you took 3.5 minutes for history and then 2.5 minutes for the exam. That's a right mix, I would say. So 30 seconds here and there is not a big deal. But you finished early and then went on to patient concern. That's fine. What is it? Investment investigations are different. And the main concern is if you want to stop the antibiotic, what to tell. And you clearly said we look into different antibiotics, spread to other people. And that's where I got a clue in terms of spread to other people. So that means you can't go home. You need to be here, isolation, ward, everything there. But unfortunately, I don't know why you thought you can go home. That's the only point against your consultation, I would say. And gut doctor, yes, you can say gut doctor, or you can say like a gut specialist or anyone, something like that. DD is okay. C. diff. So I didn't ask about C. diff management yet, but people will ask definitely. C. diff management, and we'll be thorough with that. IBD malabsorption. When I asked malabsorption, I didn't mean exactly in this situation. I asked generally in terms of malabsorption. You could have said different things like a celiac or you didn't ask specific. You said about diet, but again, be specific about celiac. If any particular wheat products make you unwell or diarrhea, I mean, it's a specific question. If you ask in terms of diet, people might think different things. So even the diet, if you say in terms of food poisoning as well, and that's an important clue in terms of ask, in terms of whether anyone else in the family got affected, we need to ask. And yeah, malabsorption, I said celiac, pancreatitis, everything is fine. And you said CBT, again, avoid the short forms, get a full form, and then say stool culture is fine, IV fluid is fine. So except for sending patients home, I would be telling everything is fine. It's perfect. I would say it's a perfect match. Anything else from you? There are a few
Thanks.
messages in the chat. Sorry, anything else from you?
No, doctor, thanks.
No, very good. Right. So, and then JVP. The question is why JVP? Again, you could have avoided. Whether it's I said definitely signs of dehydration there. Then the next question you ask about JVP, so maybe may not be relevant, but that's okay. See, if you ask like a 15 good things, relevant things, perfect things, if you did ask like a 16th or 17th, they're not going to mark you down. That is the key. And in terms of, there's another question in terms of weight change. So whether we need to ask in terms of weight change or not, I would say yes and no, because when you talk about the history of cancer, it's always helpful in terms of the weight change, but they're not going to penalize you if you didn't ask that one particular question. So it can be okay. It's towards everything, generalized thing over there, and they won't take like it's not like a list of 20 questions and then they will tick one after the other. It's just like an average. If something clear cut is missed, if this patient has a malignancy, and then if the weight change was not asked, then it's a problem. But he thought about few clues in terms of any cancer in the family, he did ask. So in that case, should be okay. Can be missed. They're not going to mark drastically down in this situation. Right. Any questions on these two scenarios or general? And now I would say, yeah, yeah,
Sir, in this case, we check the pulse and blood pressure.
yeah. I said pulse, pulse normal, 100. I said pulse.
And so could not get the answer regarding rectal examination. Can you repeat it?
Sorry, what is that?
If we are asked to do, or if we think it is needed to do rectal examination, so how we can do it in this 6-minute time?
No, no. Rectal examination won't be there at all, actually. Oh, sorry. I've just seen the like a chat. You ask about rectal examination in 6 minutes time. Just to argue, no, it's impossible to do rectal examination. Even in full examination for abdominal station, I don't think you would be doing the rectal examination. You can do, I will complete the examination, the rectal examination, and the hernial orifices, and then urine dipstick, what we do usually. But you are not, that's not the task in exam. PR exam, you can forget about it in terms of procedure.
Okay, thanks.
Okay, any other questions related to the cases or the time, or have you got any brilliant ideas to share? No? Right. How's the time? Yeah, we have got time. Shall we do another case?
Yes, please.
Can I do one more case, doctor?
So, have you got the exam date, Dr. Raj?
Yeah,
I need
When?
in 1 week time.
1 week time. Okay. Dr. Shaheen, when is yours?
mine also after few days.
So maybe a few days get the priority, and maybe Dr. Raj next time. Is that okay?
Okay.
Okay. See, both are in similar situation. Doesn't matter whether 1 week or few days. It's exactly the same. But we'll see what's going on. Right. I'm just thinking whether to, because you've got only few days. I don't want to scare you. Okay, will do. Right. Scenario is 68-year-old lady called Lucy Tempest has come to accident and emergency with dizziness. Right, your time for 2.5 minutes starts now. So I would suggest everyone to practice like this. I don't know how if you are practicing like this already. That's fantastic. Don't need to worry about anything. But if you are not practicing like this, I would suggest because the timing is important. And then in examination, we tend to get the answers immediately. Is the chest clear? Yes, clear. Is abdomen fine? Fine. Everything is fine. You can't get everything in fine within answers in exam. You need some time, 30 seconds or 1 minute, and then think about how you do it. Particularly neuro and all. You can't say neuro normal, and then you can't say oh left side weakness and the left side sensitive deficit when you practicing. So be real, and then only you get the same habit in exam to make it clear cut. If you do something different, you will be in trouble. And that's why I would say anyone with a study partner or mentor or anyone who is helping you to do the practice, just do methodically exactly the same what you do in the exam. Right, time is up. Your 6 minutes starts now.
Hello, good evening.
Good evening.
I'm Dr. Beg, one of the doctors. May I confirm you are Mrs. Lucy Tempest, 68 years old?
Yep.
We are here to discuss about your problem and I will examine you. Is that fine?
Yep.
You came with complaint of dizziness. Please tell me more about it.
Yeah, when I say dizzy, it's a bit feeling a bit vague and heavy head, and I couldn't concentrate. So in terms of the, I don't know, I'm not with it. I'm not with it. It's something like cloudy, vague, hazy, anything I can describe like that. So I can't concentrate actually.
Okay, is this first time or anything in the past?
No, first time.
Okay, what were you doing exactly when you had this episode?
Nothing. It's there all the time.
Is it like you are lying on the bed or is it like standing position?
Yeah, any time. Even now, I feel a little bit dizzy. I couldn't figure out. Yeah.
You feel more dizzy when you stand up from sitting position?
I don't think there's a difference.
Okay, when you have this, do you have loss of consciousness?
No,
Any chest pain?
no,
Any awareness of heartbeat?
no,
Okay. Anyone told you look pale than before?
no.
Okay. When this episode happened, how much time you had this dizziness? How long?
It's nearly all the time.
Like how long you are feeling dizzy when you are having this episode? All the time?
Yeah, all the time.
Okay. And what you take to recover from this? Like any sugar or any water you take?
Nothing recovered so far, and that's why I'm here.
Okay. After this dizziness, are you like alert or you confused? Still confused?
I would say I don't know. It's a bit hazy. So when you say I can talk, but not I'm not fully with it. So it's just like you've done a night shift. If you've done a night shift and morning, how it would be. That's where I am.
Okay. Any headache?
No,
Any shakiness of any part?
no,
Any weakness or numbness of any part?
no.
Any past history of note I should be aware of?
I have a motor neuron disease.
Since how long and what are you taking for it?
2 years. I'm not on this for 2 years. Say, I'm fine with my mobility and everything else, but recently I have problems with secretions.
Right.
So
And
I'm
what are
like a drooling and things recently a problem.
okay? What medicines you taking?
They put me on a patch, hyoscine they call, hyoscine patch,
Right.
a
Okay.
week ago.
Right. And any blood pressure or high sugar, high blood pressure in the past?
No, it's fine.
Okay. Besides this medicine, any other medicine are you taking?
No,
Okay. I want to examine the patient now. I will check the pulse.
normal, 82.
Okay. I will check for Hoffman sign.
What sign?
Hoffman, sir, upper motor neuron, pronator drift, I
Hoffman.
can. Yes.
Hoffman. Okay. Normal,
Pronator drift. So in the hands, pronator drift.
normal,
Okay. The power in the hand, just the flexion extension. Sir, in the wrist flexion extension, is it weak?
wait, normal,
Okay, I will check. The pulse is normal, right? And I will check the carotid for any bruit.
normal,
Okay, I will check chest for any basal creps. Any secretions, any basal creps in the chest.
normal,
Okay. Any past history of, you said, any surgery, hospitalization in the past?
no.
Any family history of similar problem?
Yeah, my dad had a motor neuron disease.
And okay, is he alive?
No, he died 3 years ago.
I'm sorry to know that. Miss, are you married?
Yep.
Okay, and how are your kids?
Yeah, they're okay. I've got 2 sons, they're fine.
Okay. And I will check the patient eyes and anything on the face, like the facial appearance. Any abnormality on the face, any cranial nerve, any damage to any nerve, can I see?
No.
Okay.
The
Any
face
vision?
appears normal. You have not examined the cranial nerve. The face appears normal.
This is normal. Okay, the secretions. You said you are having more secretions because of this medicine hyoscine. Any swallowing problem?
No,
Any difficulty in breathing?
no. 2 minutes with the patient.
Okay. And how are you your daily activities? What is your job?
I'm a piano teacher.
How this condition affecting you?
I'm okay in terms of luckily my hands and legs are fine at the moment because they were weak initially, but not to the level to make me disabled or anything like that. But I'm just struggling with my secretions because I don't know what to do because it's going on and on and on. I can't talk and the drooling of saliva is coming. So I feel a little bit embarrassed when I teach my students.
Right. Any question you want to ask me?
So what do we do with the secretions?
Yes, Mrs. Tempest. After examining you, we need to do complete examination of your brain and the upper and lower limbs. The secretion you are having is
Did you
because of.
say examination of the brain?
I will do the complete examination of and I will. This secretions which you are having is because of the medicine which you are taking for your disease, motor neuron disease. So we will give you some other medicines which will try to lessen your secretion, and you will feel better with these problem.
Sorry, are you saying I'm getting secretions because of the medicine I take?
Yes.
Oh, why do they give that?
And secondly, it could be because of your uncontrolled disease, motor neuron disease, which can damage some of the nerve cells and which are problem causing this problem of increased secretions. So we will form a multidisciplinary team involving the nerve doctor, and we will do some investigations, and we will start you on medicine to lessen the secretions which you are having. For your social support, we can provide you help at home and regarding your job and daily activities.
What medicine are you thinking it? Time is up. Examiner time. So what's the diagnosis here?
Sir, this patient has a motor neuron disease, and now she came with of dizziness off and on. She has also secretion, increased secretion. So I think her motor neuron disease need to be reviewed, and her medicine need to be reviewed, as she is having uncontrolled symptoms now.
Why do you think she has got secretions?
So secretions because of the medicine which she is taking, this
What medicine she is on?
hyoscine,
What size?
acetylcholine.
Is it highest in acetylcholine?
Acetylcholine is atropine, sir. Acetylcholine inhibitor.
Right. What are the types of hyoscine you know?
So patch form and in the oral also patch also.
Right. So what is in the patch?
So slowly releasing atropine to control the secretions of such patients like neurological deficits like motor neuron disease.
So is it atropine in the patch?
Yes, I am not sure.
Okay. What type of motor neuron disease she has?
So I think she has amyotrophic lateral sclerosis involving bulbar symptoms, as she has difficulty in secretion.
Okay. What are the two key features of motor neuron disease?
Sir, dysphagia and dyspnea and wasting of the muscles, small muscles of the hand. Features, sir, you are asking, sir.
Yeah. What are the two features which can't happen in motor neuron disease?
Yes, sir. Sensory involvement is not present. It's only motor involvement. And secondly, sensation is not lost, and the coordination is, sir, intact.
Time's up. It's done. Right. Okay. So any question?
Please correct me.
Anyone else? Anyone else want to say anything? Right. Okay. See, the history is good. I would say in the terms of like a timing wise, 2.5 minutes and 2.5 minutes. So that means like the first 2.5 minutes he stopped and then coming to the examination. Sorry, 3.5 and 2.5. 3.5 for the history and 2.5 for the examination. The mix is right. And then it's a little bit tricky when you say like a vague, heavy head, hazy, can't concentrate. Again, did you ask about fall?
Sir, no, I forgot. I had in my mind injury.
Fall and injury is main thing. And then I said all the time, and he said about whether you know bed, standing, loss of consciousness, chest pain, palpitation, pallor, sugar, water, recovering. Are you thinking of hypoglycemia?
Sir, I was ruling out that.
Ruling out. It's okay. So shakiness, headache, weakness, and that the history started disclosing when tell about M&D, and then 2 years is there hyoscine. So the examination part again, just you checked in the quick neuro, power, Hoffman's pronator, carotid root. Why basal crackles?
Sir, just secretions, I thought.
Secretion, aspiration kind of thing.
Yes, sir.
Okay, then no need about basal crackles. So you have to examine all areas of chest, isn't it?
Yes.
And he asked about swallowing problem, shortness of breath, and I said in terms of piano teacher, secretions are there, so hands are fine. I feel a bit embarrassed, and then he said, "Okay, right, next." There need to be a little bit empathy, something like that. But you told the other things. You told, but this point it's missing. And then somehow you told about the examination of brain. That's completely odd. You need to be careful about our words. And then you said about MDT, investigation, social support, joy, and activities, everything is fine. But the secretions, you're completely wrong with hyacinth. Anyone else? What hyacinth we are talking about?
It is causing it's an atropine.
Motion sickness. I think it's for motion sickness.
No, no. What hyacinth? You know the hyacinth types. I said we somebody put them on patch for secretions. That's a big blunder here. So I said somebody put me on patch for the secretions, but you said it can cause secretions. So someone put it in the chat. Hyacinth is anticholinergic that causes dryness and dizziness rather than increased secretions. Dizziness is due to medicine hyacinth. Perfect. What are the types of hyacinth? Anyone?
The oral and patch.
No, that's not the type. I'm talking about types, not the formulations. Have you heard of hyacinth butyl bromide, hyacinth hydrobromide? No? Okay. See, hyacinth butyl bromide is Buscopan. Hyacinth hydrobromide is the trade name for the patch is scopolamine or scolpderm. That's fine. It's a patch. So this is for to dry up the secretions. Either we can use hyacinth hydrobromide comes in patch. So that's where it's a minute doses. But this is again can cause sleepiness, drowsiness, dizziness, wake, and poor concentration. This is not cardiac dizziness. It's just like you said, unable to concentrate and things. This is not dizzy. See, people will talk, they are dizzy. And what exactly means is like a cloudy head, as I've told clearly in terms of when you've done the night shift or in the morning, how your head is like a confused, didn't have a good sleep. So this is not like a cardiac dizziness. Like you need to ask orthostatic hypotension, everything we need to ask. But this is clearly something like a drowsiness kind of dizziness. Do you feel drowsy? How do you sleep? And concentrate means a bit drowsy. So that is common side effect of hyacinth hydrobromide patch, which is used for secretions for, in this case, is bulbar MND. So idea is to stop and then find any other alternative and then see how things go. Or if we need to check the dose, it's 1 milligram. So if it's like, let's say 2 milligrams or so, then you can ask, when did it start, how long? Let's say with 1 milligrams, you're okay, and 2 milligrams it's not, then you can reduce the dose. So this is due to treatment related complications actually. And again, the next second one is the C. diff is also like a treatment related complication. The first one is completely new, like a DVT. New, one scenario, and then two scenario treatment related complication. We have not done anything for disease related complications. Right. Okay, we are coming to the end of the session. Any questions?
Thank you, sir. Thank you so much.
Right, thank you. Any questions from anyone? Right, so we do have lots of free session videos in the website under the video section, or if you are in Facebook, or there's a YouTube channel. You can follow up in the Twitter, Facebook, Insta, anything. So we'll see how things go. Apart from the free sessions, I also do like a paid group sessions, which is topic oriented or station oriented. And I do offer face-to-face paid sessions as well. When I say face-to-face, it's one-to-one. So you can pick and choose, make use of all the free videos, and then best wishes. Thank you. Bye-bye. There are no questions. Bye-bye.